All right. Hello. Welcome back. Well, it's a nice introduction. Well, first of all, I would like to thank the Academy and the organizing committee for the invitation to take part in this great symposium and the incredible event. Let me see. Oh, I guess I cannot walk that far. All right. Just as the introduction, I'm Geraldine from Taiwan, from Taipei, Taiwan. I have my own clinic and I run a training center and dental laboratory. So, but I'm a part-time faculty at Harvard School of Dental Medicine. It is a great honor and pleasure being here. And for the next 45 minutes, I'm going to share this topic with you and regarding the vertical ridge augmentation. So, I think we're missing. So the outline today for this presentation, we'll go over the several basics and then also clinical cases. Hopefully, we can have certain understanding of how to achieve vertical ridge augmentation via different techniques and via different decision making. Hope you will enjoy this 45 minutes. So yesterday I went to the highest building in Bangkok, and if you look at here, there are a lot of skyscrapers in the world, and you're looking at the vertical bony defects. It's just like building up the skyscrapers. There are so many different types of construction, different techniques. It's just like in dentistry. We're trying to use different techniques, or we're trying to use the same technique to build up the building, or just build up the building just like building up the building. So what I'm trying to do is there any way that we can find out a certain principle or protocol that we can follow and we can do our bone augmentation predictably? So that's the mission I was gonna do for today's presentation. So first, we would ask what and how to make our decisions, because making clinical decisions essentially is very important. And of course, we have so many different techniques and also different type of defects. So making the correct decision is our first step for success. And what I would like to conclude, well, before I start this presentation, is it's all about timing and techniques. Why is that? Timing is so important in my opinion, and also for my technique. So if you look at those two defects, they're pretty much the same. If you look at that, there are the lower anterior, the bottoms, they're missing lower front teeth, and they're missing teeth. But there was a little bit different. If you look at those two carefully, one is a fresh extraction. The other one, well, there are a lot of holes because I did intrametal penetration. It looks the same, but actually it's not the same. They are different because those two wounds, even though they look the same, they locate the same area in our mouth, but they react differently. So we have to take different strategy and different techniques treating those two cases. So we cannot use the same protocol for those two. So just remember, not all the wounds and sites are the same. So that's the very first thing we have to keep in mind. I guess this is the far I can go. All right, so I guess I need to use manually. If we look at the literature or articles, not many articles ever talk about the healing potential in oral cavity. But we're lucky. We have one very old, 1982 by Evian. The other one, 2008 by Trombelli, actually tells us that our healing potential decreased over time after the extraction. And if you can find something very similar in those two articles, they all point out after 8 weeks, the healing potential decreased. And well, based on one, I'm writing it, well, I already submitted a new article that I pointed out, actually, it's not 8 weeks. We can do our procedure. We can extend it to 12 weeks, and we still get very good results. But I'll update to you later on, but not in this presentation. So if you look at that, we have two different types of healing potential, high versus low. So if you look at those two cases at the previous slide, one present the extraction side. It's more active for healing. The other one has been extracted for a while, and it shows a very slow healing potential. So in order to treat those two cases, we have to use a different strategy. So I kind of categorize our wounds into two. It's very simple. It's just low cellular activity and high cellular activity. It's quite simple based on the time after the extraction. Even though there are articles indicated that 8 weeks would be the cutoff, but I would like to present to you, we can do the procedure delayed to 12 weeks or even longer. So before we take off for the presentation, here it is. Before we do any procedure, we would like to have good soft tissue. That's very important, especially for vertical ridge augmentation, because the vertical ridge augmentation is very difficult, and the key, I would say crucial key, is to have good tissue, so we can close up the wound, like primary closure. In order to do this, pre-surgically, we have to evaluate the soft tissue. I'll give you those two examples. One, when a patient came to my office with infected membrane and a failed bone augmentation procedure. The other one, patient came to my office with active infection with exudation and pus discharging from the defect. So pre-surgically, we have to look at the sites carefully. On the blue one, because the tissue was not good. So what we have to do, we have to be patient about it. So we have to let the tissue grow. So in order to have good tissue for the surgery, we have to wait. So I send the patient back to the dentist to have the membrane and bone tag removed. Then I just be patient to wait. So I have patient come back and evaluate the soft tissue. While the other one, I extract the infected molar. What would I do? I just extraction and did nothing, just wait as well. Why? Because I wanted to have the infection under control, and the inflammation should be under control before we do any major procedures, okay? So the middle one, when patient came back and I found that we gained soft tissue because our mother nature had given the healing for the soft tissue, but we didn't have enough. So what did I do? I took a piece of connective tissue from the palate and grafted on the canine, because on the canine it's not enough in terms of thickness, in terms of the keratinized tissue. So that's the first step I did to have good soft tissue. But if we don't have enough, then we have to graft it. The second one, the infection actually went away, right? So it's just simple. After extraction with antibiotics, and we didn't have a severe infection any longer. So the one I did a connective tissue graft, I did have better soft tissue profile and better soft tissue contour and texture-wise. The other one, because the infection is gone, and by 6 weeks, that's enough healing for the soft tissue. So I started working on the augmentation procedure. And the middle one, after I did have enough soft tissue, that's when I can do the vertical augmentation. If you look at the defect, it's a vertical bony defect, completely missing the buccal lingual plate. And it's more than 10 millimeters of bone loss. And I put 3 tendon screw and removed the incisive nerve bundle. While the other one, of the extraction side, I put the bone graft, resorb membrane. Well, unlike the resorb membrane, the center one, I use non-resorb membrane. Why is that? Because this side there's so many surgeries been done, and then all fail, and of course it's a chronic side, even though there was a failure, because I got to wait this long, so the healing potential decreased. Then I was not able to use a resorb membrane to achieve a better result with that. Then I used non-resorb membrane. On top of non-resorb membrane, it's a titanium reinforced non-resorb membrane and tenon screw to maintain the space. Then I suture it up. So both sides. Then the other one, place the implant. Whenever it's the bone mature, I place the implant and graft it again, because if you look at the other side, I couldn't, at the time of the uncover, I couldn't find the tenon screw. So I have to drill it and place the implant. And that's a tenon, the hole on the buccal, the adhesive actually is the side I need to remove the tenon screw, because it's all buried down there. So in order to remove the tenon screw, I have to dig it out. But when you look at the bone augmentation, it's quite successful. And for the middle screen, well, it's the augmenting. I wait for about 18 months. When I open it up, see the bone, I have enough bone grow all the way and across, or even beyond the tenon screw. That's more than 10 millimeters of bone augmentation, right? And the other side, it's ready for the soft tissue procedure. So on the central screen, I placed 2 implants. The other side, I did a free graft, and just to correct the soft tissue. If you look at here, I correct the soft tissue problem to gain keratinoid tissue. So this is the result. So if we look at those 2 cases, why should I wait? Because I need soft tissue. I need the characters of the soft tissue. I need not only the texture, not only the volume, but also need a very healthy tissue. Then that's a cue that we can proceed for vertical ridge augmentation. So it's very important. Before the surgery, then we have to evaluate the site and then to perform it correctly. So timing. The timing wise, when I look at when I talk about the timing, it's based on, there was a study by the publication by Dr. Boozer regarding the timing issue. So after the extraction can be categorized into immediate, early, and late. I kind of modify it a little bit. So for the immediate, that means I do it at the time of extraction, means immediate implant placement, socket augmentation, socket preservation, all do it at the time of extraction. What about early? In the past, the early means that there was a period of time they'll call early, but I think we can subcategorize as early and late early. My point is that early means soft tissue. That just like those 2 cases, I need certain time to have soft tissue in order to perform the surgery. So the early means that we can grow soft tissue. That's a period of time we need it for the soft tissue. So in general, it's 4 to 12 weeks. Well, 12 weeks, I put the time, 12 weeks, because I found 12 weeks still work. And the late early means that there's a partial bone healing, and it should be after 10, 12 weeks. So I put it 10 to 16 weeks. So in this period of time, there was early. Means that we can do the booster, the early implant placement, or I call it another way of bone augmentation as early bone augmentation. This protocol I've been using for a long time, and there was a publication I just submitted. It will be published either this year or next year regarding a vertical ridge augmentation with early bone augmentation protocol. So this is what I would take advantage of the healing. And if we wait too long, just like the case, because the soft tissue issue, then I need to wait quite long to 16 weeks. Then we are having the late approach. means that we need to use something stronger, the non-resorb membrane for it. So that's why the conclusion, why does the timing matter? First of all, it's healing potential. We can do things we have to do it as soon as possible. I call it asset concept. Means that we do it as soon as we extract it, then we take advantage of the healing potential. The second is soft tissue. Sometimes we just need to be patient about it, so we wait because we need to grow soft tissue. And of course, when if we bump into the problem that the case presented as a pus, active infection, then we need to get the infection under control. So that's about timing. The last one is that how we should do it correctly to choose the right material, because apparently if we wait too long, we have to use a stronger space-making material. If we don't, then we can use a resorb membrane. So how simple it is, right? So the healing potential. That's, this is, for example, socket augmentation, immediate implant placement. I'll take this for example. This case, for example, when patient came to my office with a recession, with a bone loss, like this, the tooth is still there, there's a fractured tooth on the central. Well, apparently I found that we can do it immediately. That means that we can take advantage of a healing potential, so we can do it as an immediate implant placement. And of course, there are buccal dehiscence, bone loss, tissue loss, then we have to graft it. So I extracted, if you look at it, it's a huge buccal dehiscence, and of course some sort of lingual bone loss as well. But we take this healing potential, and we can grow bone, we can place the implant, and of course we amend the soft tissue deficiency. So I placed an implant, grafted with a bone graft, collagen membrane. I took a piece of connective tissue from the palate and suture it up. If you look at it, this is the primary closure, right? As I mentioned, the primary closure is the best healing environment for vertical ridge augmentation. So you have to keep in mind, if you want to achieve that much of the bone growth, we need the primary closure. So this is before and after. And probably you or me will question about how this could last. Can it last longer? Could it be just long-term or short-term? And then I'll show you. In 8 years, patient came back. See on the left of the screen, still there's the same implant I placed. And it's no recession, no further bone loss, very healthy. What about longer? When we wait for the 14 years, when patient came back 14 years, still the same. So that means that we did grow bone, we did grow soft tissue, we did augment the bone well. So, and the key is that we take advantage of the healing potential. So the socket management, that is important because we do it as soon as possible. That's asset concept. So let's come to the material selection. Material selection means that we can make the most of our procedure, and then we take advantage of the material. So when you look at the concept of tissue engineering, there's a tissue engineering triad that we have cell, we have the molecules for growth, and then we have the scaffold. There are three major essential elements for tissue engineering. But if you look at carefully, actually, my perspective is looking at, are we dealing with a lot of cells or a few cells? For extraction, that's a lot of cells. For the chronic side, that's fewer cells, right? For the molecules, we don't have the biologically active molecules available for commercial. Nowadays, we're lucky in Taiwan. We just had the PDGF available in Taiwan not long ago. But if we don't have, like in the past, I didn't have it, then I use patient's own blood from the bone marrow. Okay? What about scaffold? In tissue engineering, scaffold is important, but in dentistry, in bone augmentation, actually we're looking at space making. So we have to look at the space making property in order to gain bone. So there are three things in between. First, primary closure. Anything We need cells and we need space making, we need primary closure. And timing-wise, it's between the cell and then the growth factors that there should be, we can take advantage of, that we can take the time, we can take the asset concept to do it earlier, then we will be able to utilize the healing potential. And the bottom one is, well, between the scaffold and the molecules, then we have the blood clot that help us out. So I'm giving this example of scaffold and cell space making. If we have a lot of cells, the same scaffold, we don't need a strong space making, right? But if we have fewer cells, like to the left, on your right, you can see fewer cells, the same scaffold, then we do need a stronger space making material. So that's how we can pick our material. And there are two major factors, as I mentioned, cell and space making. If we have a lot of cell, meaning a healing potential great, like extraction, fresh extraction site, or ongoing inflammation, that's a lot of cells presented. If we have a chronic site, that's few cells. So we need a stronger space making. So in terms of space making, if we have a good healing, resolved membrane. If we don't have non-resolved membrane, that's quite simple. And we do need something to add up as a tenting or any that reinforced material. So the bone graft, we can choose, well, I like to choose allograft, xenograft. I don't use alloplast. And those materials that you can choose are very good, something that would add on for bone augmentation. That's the bone graft. I don't use autogenous. For those cases you've seen, I use zero autogenous. I don't like to take autogenous from patients' ritual molar or the chin. I haven't done it ever since 2007. So all the augmentation I presented today, there are zero autogenous bone, okay? And then the membrane-wise, we use the collagen membrane, we use the non-resolved membrane like I did for the difficult case. So protocol, I will present to you two protocols that for the section side, it's fast healing. So we certainly use a resolved membrane because resolved membrane for the bone augmentation, I like to use a long-lasting type of collagen membrane. For heal site, means that there are fewer cells, the healing potential decrease. I use non-resolved membrane. Of course, there are a lot of different types of non-resolved membrane. I like the titanium force DPTFE. Well, I think titanium mesh would work as well, but I just personal preference. I like to use the DPTFE because easier handling wise. A lot of consideration you have to look into healing potential, soft tissue, as I mentioned, and of course the defect dimension. If we have a huge defect versus small defect, then we should think it differently, all right? And of course, we do have different protocols for each type of considerations. So I'll give you the scenario number one. Scenario number one, when we have high cellular activity, means that there were great healing potential, means that there are a lot of cells, either it's from extraction side or from implant removal side. I consider implant removal site not equivalent, but similar to extraction of a tooth. Why? Because they're same consideration, very similar information type of defect, right? And of course, our body would have all the cells, ingredients coming to the site to help out for healing. So they share the very similar type of healing. So I put them as the same category. And I just want to point out again, primary closure is very important. So I'll give you this example of a socket augmentation. Patient lives in Vietnam and came to my office with multiple fractured front teeth. And of course, there are some difficulty of it. First of all, it's been infected and a traumatic bone loss. And patient live abroad, is not even in Taiwan. So there is some consideration. I'm thinking if I was not able to place the implant immediately, what should I do? Do socket augmentation or do delay early? Because it's not possible for patient to come back based on the time frame of the extraction, right? If I want to do the early protocol, it's not possible for her. So what I did, well, apparently I extracted and I found it's not possible to place the implant immediately. So my choice is to do the socket augmentation. Because if you look at the defect, there's a vertical defect, buccal, lingual, bone loss, central better, but then those two laterals, the tremendous defect is a vertical defect. If you consider that it's both buccal and lingual plate. So I extract them and I graft it at the same time. To be honest with you, my first choice, my top one choice would be early approach, early bone augmentation. I will extract it, wait for 8 to 12 weeks, and patient come back and do the vertical augmentation. That's easier. But because patient was not able to come back within the time frame I gave, so I decided to do the socket augmentation. So I have to graft it at the time of extraction, and I use a long-lasting collagen membrane. The most important thing is that primary closure, right? So if you look at the screen, this is a multiple extraction. I close it up as a primary closure approach. I don't even leave any of the open membrane approach. Why? Because this is a vertical defect. It's not something that is good bony housing, so we have to close it up completely. And let's wait for 7 months so a patient come back. If you look at the bone, right, we have enough bone for implant placement and place the implant at correct position. So I place the implant on the laterals and they healed up. Then what should we do? Remember, in order to close up the wound, I move the tissue all the way up. So I kind of move the mucogenial junction. And also for the aesthetic zone, it's better to have thicker tissue. There are a lot of articles you can quote. Based Joseph Kane 2006 that indicate we don't have enough tissue on the buccal of a natural dentition, as in average about 0.6. Then we need more of soft tissue. So for this particular case, I did a connective tissue graft. I took the graft from the palate. This is a new technique I invented not long ago. This is the very first few cases I did modify nowadays. So this is a very few one, trial. So I did it differently than before, but very similar type of approach. I grafted, and then the way I grafted just like free graft to the bottom, and then I close it up. So I bury the connective tissue underneath the flap, and they get healed up. Once it healed up very well, then I can usually let patient come in around 8 weeks or even longer, and then I would do deepithelialization. I use a laser. Well, any way you can do to deepithelialize the surface. The reason why I'm doing it is because I would like to get the keratinocyte tissue. Why? Because if you look at the article, the phenotype is determined by the genotype underneath it, right? So by carrier study. So I just use this principle, and I bury my connective tissue graft, and then they healed up, and then I deepithelialize it. So in this way, I was able to get keratinocyte tissue. And of course, I have enough tissue thickness underneath it. So we have a very good result. So let's go to the scenario number 2. Scenario number 2 is still high cellular activity, but we can wait. And that's my preference. Post-extraction, post-implant removal, or any post-inflammation. So whenever we need soft tissue, then I use this protocol. If there's a vertical bone loss and I need soft tissue to close it up, I use the early bone augmentation protocol. So I'll give this example, post-extraction. Patient came to my office with fractured front teeth, and because multiple trauma, so the previous dentist splined them together, and there was severe infection as well. So I was not able to treat it at the time of patient came in, so I extracted later on, and I didn't do anything. I just extracted, and then it healed up. Because let the tissue heal up, then I have enough soft tissue for bone augmentation. That's what my purpose for it, okay? Then when I open up, if you see, this is huge defect, right? Especially there was a big, huge concavity, the middle and apex. So there's no way we can place the implant without any bone augmentation, major bone augmentation procedure. So what I did, well, just because the early augmentation protocol, I don't need to use any non-resorb membrane at all. I just use, this particular case, I use the resorb membrane, long-lasting one, and graft it. So after I have the bone healed up very well, so I place the implant in a very correct position. And of course, I use a contour augmentation again. And later on, I started to graft the soft tissue. Remember, when the patient came to my office, there was an infection of the tissue. So after the inflammation getting under control, there was some sort of shrinkage of soft tissue and of course the bone. So in order to correct the soft tissue deficiency, then I did connective tissue graft just to augment the soft tissue. And well, I didn't do the epithet because I didn't really pull the tissue up. So I uncover it, and this is the final restoration. So that's about the early approach I mentioned about. And what about anything that about extraction of the implants? This is post-extraction of the implant or implant removal. So when patient present this very long, very old implants, like this very old-fashioned of a machine service implant, and there was a recession. And of course, a patient had this restoration as open bite. She didn't even aware of that's a problem, but she mentioned that it's so odd because she had the restoration done, and then it was a gap, and she was not able to function well, especially for eating and for netting. So I extract those two teeth, the two implants, because they are malpositioned, and of course there are bone loss around it. So I extract those two implants and wait for the tissue to heal up. Then I open it up. If you look at the defect, those two implant sites, they're quite active. But the site next to the extraction site, there were atrophy ridge. So in order to do the augmentation, I have the protocol as a hybrid approach. Means that I combine non-resorbable membrane and resorb membrane. For the center, there's a higher healing potential. I use a resorb membrane. While on the side, I use a non-resorb membrane. Why is that? Because the extraction side, it presented a very fast healing, so I don't need really strong material to hold out the space. While those sites that have been atrophic for a long time, then I do need to hold it up. So I did this, but unfortunately, there was a pandemic during the time. So she was, I lost the follow-up. In 6 months, she came back. There was a tiny membrane exposure of non-resorb membrane, but it's not a problem. Remember, I did it as a hybrid. So I just removed that part of the non-resorb membrane and let it healed up. And by 5 months after membrane removal, that's about 1 year after bone augmentation, I achieved very good bone profile and ready for implant placement. So I placed the implant as for the implant supported bridge approach. And of course, I grabbed the connective tissue graft for augment the soft tissue for aesthetics. This was a very early first few cases that I did augmentation, and then I did epithelialize and then gain canine tissue. And that's when I found this could be a good protocol. And I present this protocol just last 2 weeks ago at the American Academy of Periodontology annual meeting in San Diego. So a similar type of soft tissue approach. Then let's come to the scenario number 3. What's the scenario number 3? Means that we have something sort of atrophy rich, very slow healing, very low cellular activity site. Means that edenturism for a while. Patient lost the teeth for 30 years, and atrophy rich. It's not possible to use a resorb membrane to build up the high, especially for vertical augmentation. Then I use something that's stronger space making, titanium force PTFE or titanium mesh. So this is how it is done. Incision-wise, I like to use buccal crescent incision for this type of vertical ridge augmentation and full thickness flap, decorticate the site, and pack in the bone, adapt the membrane. Kindly, there's a lot of different type of technique you can apply. I personally like to pack the bone first and put the membrane on top and use a tack or a screw to immobilize the membrane, and then do tension-free closure. Anything that vertical ridge augmentation would be achieved, then tension-free closure is very important for primary closure. So this is how the procedure should be done. So I'll give you this example. Single tooth space. When patient came to my office, well, apparently it's male-treated. There was male position implants, and of course the edenturism site, and atrophy reach, loss of buccal and cornal, vertical horizontal bone loss. It's single space, single tooth space. I decorticated, put it in the bone, non-resorb membrane, and put the tissue, close it up, and suture it. Well, in 10 months, then I was able to, to have this type of bone augmentation. And it's not a problem for us to place the implant in the correct position, angulation for aesthetics. And of course, I did another contour augmentation, and then soft tissue grafting with roll technique. And this is the final result. So if you look at this single tooth space, we can easily build it up, because once we have a good bone, good soft tissue, the aesthetics just on the way. So it's not that difficult for getting the aesthetic result. So you look at this lady, she was almost desperate from those dental treatment done before, but then everything can get back to normal, or even better than what she had long before. And that's what we were so grateful about it. What about multiple teeth space? When we have multiple teeth space, it's more difficult. Patient had this edenturism area being done a couple of surgery. There was a few failure bone augmentation and referred to my office. Then when I open it up, it's not only horizontal bone loss, but vertical. And then you can appreciate that there's been, there are a lot of scar tissue, and the tissue apparently is not good enough. But then I didn't do the soft tissue correction because it's good enough for augmentation. So I did a hybrid type of approach as well. Did non-resorb membrane and resorb membrane, and a combination. In 10 months, I would have enough bone for implant placement. So for this particular case, that's a long before, so I did connective tissue graft, and later on I did free gingival graft. Very similar, but I don't do it any longer. I do connective tissue deepithelialized protocol nowadays. But this was done long before, so it's done with connective tissue graft and free graft. So let's move to the large vertical defects, both bone and soft tissue. Number one is a vertical bony defect, connective tissue deepithelialized free graft. So patient presented with multiple implant failure. I removed them all, leaving this huge bony defect. And the same protocol, I just grafted. Because it's a huge defect, I just use a non-resorb membrane tennis screw principle. Close it up well, and then by about 18 months, I was able to achieve good bone for implant placement. And then I grafted with a connective tissue graft and free graft. That's an old technique, so I did twice. connective tissue graft and free graft to gain both volume and keratinized tissue back. So this is the result. So if you look at those cases, and then we can really gain those aesthetic back. The number 2 is, of course, vertical bony defect, connective tissue graft, free graft. So this tremendous defect by patient had the surgery done, and it's an open bite patient. It's more complicated, and she had the surgery done at other office, and apparently it doesn't work. And then there was one implant I have to remove, and I let the soft tissue heal. And when I opened it up, I found there was a non-resolved membrane buried inside. That was a failed procedure. So I removed it. Can you see there was a huge defect? And because there's an open bite, so it's even larger. But our patient didn't want to correct the open bite, so I grabbed it, just trying to gain the bone vertically as much as possible. Then luckily we have enough bone vertically. Then we were enough to place 3 implants for the edentulous area. So of course I did a connective tissue graft and followed by the free graft. That's a very old case, so I did it. So if you see the case with really long teeth, it's because she was like anterior open bite and she didn't want any ortho correction. So I have intentionally getting her longer teeth for the phonetic and for the function. So there's a 5-year post-op, we can still function very well. And aesthetically, she was okay because she had a very low smile line. Another case, the vertical bone defect, I start doing the dual function technique. Patient has a fractured front teeth and a midnight shift. The disaster, she working in Singapore, so I extract those teeth and wait for soft tissue. And then she came back, that was a vertical bony defect, and of course a trophy reach. I used a 2 membrane to build up the bone and close it up. Then she went back to Singapore, and then there was a pandemic, so she didn't come back until the pandemic is gone. So when she came back, and then she came back before the pandemic. I placed 2 implants, grafted, but she was not able to come back for the uncover until the pandemic is gone. And after that, I did a connective tissue graft, build up the soft tissue, and this is the result. So it's not ideal because it was she lived in and worked in Singapore. So I didn't have much chance. That I can only have 1 shot for the connective tissue graft. So if there was a little bit more of tissue I can get, then that area would be better. But it's so much better than she used to have. Another case for another vertical defect, the patient has showed this kind of defect and discrepancy of the gingival line. So I removed that hopeless tooth and did that procedure so that what I presented, grafted. And the central got a fracture afterwards, then I extract the central and place it immediately and grafted again. So this is how I correct the soft tissue nowadays. I did partial thickness, and I pushed down the tissue, and I took connective tissue from the palate and grafted that the way we did for submerged the connective tissue graft. And they healed up for about 2 months. Then I can go ahead and did the epithelialized procedure and get keratinized tissue back. In this manner, the aesthetics would be easier to achieve just with a 1 connective tissue, soft tissue grafting procedure. Unlike in the past, I had to do 2 times, okay? So this is before and after. So what else? So there are peri-implant defects that can be done with the protocol I mentioned about, the peri-implant GBR. For example, vertical bony defect around the implants, peri-implantitis. And how could we do it? Of course, I let the tissue heal and cleaned out the defect. The way I cleaned out defect by hand instrument, by air powder abrasion, by laser, by tetracycline chemical decombination, and then I grafted it with bone graft and resorb membrane and close it up because it's just like fresh extraction site. All right, so there's 3-year post-op and 4-year post-op. So let's get to the aesthetic zone. Aesthetic zone, it seems things sometimes more complicated because it's difficult to handle the aesthetic zone. For this particular case, it's the aesthetic peritonitis in the aesthetic zone. So very similar approach. Remove the prosthesis, graft it because the fresh is active site. So we can do it and graft at the same time. And then 3-year post-op. So the very last one, growth factor enhanced. What would we expect? Nowadays we have something new, like not new actually. In Taiwan we just have this. So I didn't have a lot of cases, but this is a case that I'm looking for. In the future, there are complicated cases like this, peritonitis and periodontal defect. So I was able to do the bone augmentation around the implant and do the periodontal regeneration on the adjacent teeth at the same time with the help of the growth factor. Hopefully this will change our industry, our clinical procedures, make it easier for us to achieve the bone vertically and of course around the teeth and both around teeth and implants. So I didn't have the result yet, but it's all submerged, so I'm pretty sure that it would heal up nicely. Take-home message for today's presentation, hidden potential of the defect we should take into considerations. It's very important to take the hidden potential as major considerations for choosing your material and make your clinical decisions. And primary wound closure is always important. The number one essential, crucial elements for successful vertical ridge augmentation. And early bone augmentation not only make primary closure earlier, but we can take advantage of healing potential and healing power. So it makes things easier. And with a large or low cellular activity sites, we do need a stronger space-making material, such as titanium reinforced DPTFE membrane or titanium mesh. Then that can help us out, but then it's more difficult, more technique sensitive. And growth factor maybe is something that we can use to help out for us for our procedure and make things easier and better for healing. I'm hoping that would something we can use and get things done better and easier. And vertical ridge augmentation could be achieved, of course, with a multiple approach. And most important of all, it can be done predictably. Unlike long before, when I was resident, it's always unpredictable vertical ridge augmentation. But now we can say it's predictable, and we just need to choose the correct technique and pick the right time to do it. I would like to thank for your attention, and I know I kind of a little over time. So if you have any questions, you're more than welcome to reach out to me by email or social media. And I post some videos on YouTube. I'm not a YouTuber. This is just for free for students that they can look into those videos. They keep on learning it. So it's just free for everyone to look at it. Okay, and thank you for your attention.